Hello and welcome to the Association of Academic Radiologists, or AAR's webinar Grand Rounds. I am Cecillia Mercado. I am a breast imaging radiologist at NYU Grossman School of Medicine and past president of ACER. Thank you all for attending today's session. Each affinity group is given the opportunity to host one of these events, and this evening it's ACER's turn to host. The topic of tonight's session is customizing your journey in diagnostic radiology. We're really delighted that we have two great speakers, Dr. Ryan Peterson from Emory University and Dr. Gaetke Udager from the University of Michigan, who will speak on different aspects of tonight's topic. After their presentations, there will be time for questions. So please, as the event goes on, feel free to put your questions in the Q&A box, and they will be able to answer them at the end of their presentations. So I will start with Dr. Ryan Peterson. He is Associate Professor at Emory University School of Medicine in the Department of Radiology and Imaging Sciences and has a joint appointment in the Department of Emergency Medicine. He attended medical school at University of Tennessee Health Science Center and did his diagnostic radiology residency at Emory and stayed on at Emory to do his neuroradiology fellowship. He currently serves as program director for diagnostic radiology residency at Emory and APD for the IR integrated residency. I always say condolences to you. He has done extensive scholarly work in the field of neuroradiology, but he has also focused his academic efforts in medical education, curricular design, and in how to be a better teacher, educator, and mentor. His topic today will be on customizing your journey and specifically educational tracks for specialized training in diagnostic radiology. Ryan?
Thank you so much. I appreciate you the invitation to come here. So today we're going to talk about what we do here at Emory. We have a lot of educational tracks to help sort of make your diagnostic radiology training a little bit more special. So I have no financial disclosures, unfortunately. So we have a lot of people that come into the system. They have all these different diverse backgrounds, different places they've been, different personalities. We try to funnel them in to radiology. And, you know, we love the ACGME. They try to really have a standardized curriculum. But in some ways, you don't want everybody to look the same. I almost likened it to my favorite Krispy Kreme donuts. They build a lot of donuts, but they all look the same. And, you know, a lot of times I think that can lead to not having a good work-life balance, not being motivated at work, things like that. And so what I'm here today to sort of talk about is the different pathways you can take within radiology, sort of putting the frosting or the different toppings on a donut a little bit more differently. So the objectives today is to review some of these different educational pathways, some design considerations when designing these pathways, and some tips and tricks for maintenance. Now, the first thing that we want to do is make sure that we're good radiologists first. And we have a lot of different fellowships, a lot of different clinical pathways that you can take. But this is something, we even have mini fellowships, but this is something different that when I'm talking about today. Here at Emory, we have different tracks that can sort of make your education a little bit more subspecialized. And those would be global health. We have a molecular imaging pathway. We do informatics, quality improvement, clinical education, and research. Now, these are within the diagnostic and interventional radiology department that you can sort of subspecialize or have additional training. Now, the basic design for this is it's a longitudinal pathway. It starts in your R1 year, and you do it the whole way until you grow up to be a real adult radiologist. Some of the tracks you match into with a separate NRMP match number, like research. But most of them here at Emory, we apply during your orientation year or early in your first year. And the basics of it are three different sort of pillars. And the first is having a small group series, having a practicum, learning something and actually practicing what you're learning, and a longitudinal capstone project. So the first thing is, you know, you have to give these residents time to do these different tracks. And we allow for one academic day per month for some of the tracks. We'll talk about research in a second. For these small group series, we require them to actually attend. They can be teaching that happens in these small group series. You can work on your capstone projects during these academic days, or presentations. If they abuse these academic days, you can lose some vacation. But you can also get extra special, if you have special opportunities or things that you need an extra academic day, we can do it. But for these tracks, we actually give our residents time to participate. Now, the capstone project, it's a longitudinal, tangible product that at the end of the residency, they have something that they can present at a national conference or a paper. The practicum is important because you're actually taking theory or what you're learning and applying it. And that can be teaching students, lecturing students, participating in real life like meetings or informatics meeting, creating a new device, products, or workflows. So in each, those are sort of the basic designs of each of those tracks. But more specifically, for instance, the research track. It's actually at our institution a separate match in our NRMP. We actually go out and look for people interested in research. We give them protected research time. It's about 20%. It can be more depending on if they get other grants. There's research mentorship. We actually try to get mentors and our research residents together. And also, we've had significant success. We don't have a T32, but we've had significant success with getting RSNA research grants. Now, these are some of our residents. We take about 2 per year. It's again, like I said, about 20% of their time is protected. We're currently redesigning, so the research time is in blocks, but they can get additional time if they get additional grants. And we've had no issues with any of our with having that decrease in clinical time with anybody not performing well on boards or their clinical capabilities. Some of the projects that they've done, for instance, WASF is doing a project on eye tracking evaluation to help in an educational platform, helping. He has a grant. He received a grant in 2024 for research development to look at addressing perceptual errors in radiology by eye tracking metrics. They also have other of our residents going through and using AI to identify errors in radiology preliminary reports, even presenting at SIM about using language models to actually help tell the difference between an attendings report and a resident's preliminary report to help give feedback to our residents. We have residents that are actually building catheters and trying to make products for market. And we try to get our residents sort of in the national public stage to show what the interesting things that they're doing. We also have wonderful mentorship. This is one of our residents. I think he might be on today, but a mentorship with that. We also have combined efforts between different tracks as well. This is actually a research track resident that's doing some work with the clinical education track and dealing with gadolinium and other stuff like that. So that's research. The next one we have is molecular imaging. It's basically a nuclear medicine fellowship within a DR residency. There's a 4-year and a 5-year pathway. The 5-year is an added year for research and clinical training. But this is for those clinical leaders in nuclear medicine, either at an academic or even a large private practice. And in this program, you will actually get certification to requirements for ABR and ABNM. So it's pretty cool. They get extra time in the hot lab. They do research. They have diagnostics, but they get a whole lot of physics as well. We try to create a good group of people to get together and sort of have a community. So it's very important. The next track that we have here is the global health, and this is a very big one that people are very interested in coming. It's teaching our residents to become stewards of global radiology. It's designed, each resident designs and executes a global health project. And it's not just international, like we talk about global health, but we have local health in some underserved populations here in Georgia. And it aligns a lot with our School of Medicine because we have some global health projects in the School of Medicine, and our department really helps align with that. Our residents will do some practice with ultrasound machines. Ultrasound is a great resource throughout the world and readily available. So they'll get some extra training on that. Here's Zofia, one of our residents out in Ethiopia, actually doing ultrasound on clinical patients. They'll go out and teach both in lecture halls, but at the workstation. So there's a lot of teaching out there. It provides an opportunity for our residents to go out and build relationships with some of our sister institutions like Addis Ababa Black Lion Hospital. But you get to travel as well. This is Lalibela in Ethiopia, and we have a great relationship with them. And we've tried to expand to things like Tanzania. Our hospital here has a global health residency scholars program where it's a year-long project and involves multiple residencies, not just radiology, but you actually get to go do a month-long rotation in Ethiopia. And a lot of our residents have participated in that. This is the refugee in Clarkston, sort of population in Clarkston, Georgia, and we provide free ultrasound clinic staffed by our techs, our medical students, our residents, and faculty. So it's an opportunity there for global health. We have a chapter of RAD-Aid, and we also have funding resources. And this is the thing that usually requires a lot of funding. We have an internal adopt a resident sort of grant. We have RAD-Aid, we have Road to IR, but also other donations that come in from graduates of the program, and School of Medicine has a FIT grant. So these are some funding resources to help with our residents in that track. Now, quality improvement, this is to residents that want to search for careers in patient safety or quality improvement. The curriculum is focused on things that are inside and outside radiology. So it's not just radiology, because there's a GME, QI, and patient safety course that they can take. But we also have specific radiology courses that they work with. And, you know, a lot of it is the improve, innovate, and collaborate leadership models that we all get. But they actually have time together to go through all of those different processes, evaluating the workflow, evaluating root cause analysis issues. So they actually participate and learn how to do that. They present at meetings. And, you know, one of the projects that I was told about is like translating our reports from something that the lay person might not understand, and using AI to make it into a 7th grade level report. The next is our informatics sort of track. And this aims to improve like the efficiency of the medical imaging system. You get further qualifications and skills for the tools that we use in radiology daily. It's not just theoretical stuff, but you're actually working hand in hand with informatics and IT here in the hospital, and it helps foster leadership and scholarship. This is a workflow that they're working through to sort of how can we make it better, how we can make the more efficient, how can we make the process of imaging get from the modality to the radiologist. They participate in IT operations meetings. They have small group discussions. There's a lot of mentorship, and they actually work on completing multiple projects that are in the department. Now, they also are required to have a deliverable, whether that's a presentation, but they also get to they can either complete the EPIC Physician Builder Certificate, or take the examination to become a certified imaging informatics professional. And so when you get out, you already have that, and that's very marketable for the future. We have our AI, it's called the HITI Lab. It's sort of the group of people that are working on AI research and processes. We also have a great relationship with Georgia Tech to help with some of the devices and processes and software that we can use in radiology. We have residents out there publishing, showing off at conferences, presenting, and being part of that informatics community. And it's great for people that are wanting to be experts in imaging, or want to be industry consults, or even have leadership roles in CIOs inside the hospital. Now, the last is one that's near and dear to my heart. It's the clinical education track. I ran this for years. It's for those residents that are interested in teaching. It's building the future educators of radiology. And it's designed for people, mostly for academic practice, academics, but also for a private practice career can be helpful. There's mentorship, and we try to get our residents involved in national societies, and we also have topics and discussions on how to do educational research. In our small group series, it's everything from CV writing, how to do a great PowerPoint presentation, adult learning theory. We learn how to do presentations, journal clubs. We all don't wear, they're not all men here wearing gingham shirts, but we do show and tells. And we actually have them go out and teach, whether it's R1 lectures or other subspecialties, the APPs, or medical students. So we want them to go out and teach. Some of the projects they've come through in the years is a curriculum that we still use for our first year radiology residents. We've had projects where we have the medical students simulating a cloud-based PACS system and writing up that case report. We've had in the past residents go out to the ICU and rounding and teaching the internal medicine people about the medical imaging. And also designing and developing AI sort of virtual reality or augmented reality processes for learning. Now, there's a tons of different projects that they're using, and it's each individually chosen by the residents. These are some of the capstones. They're learning. We ask our residents to also go to faculty development courses, and our school of medicine lets our residents go and participate on how to be better learners. So how do you do this? I have just described 6 different pathways you can go. Well, just start one step at a time. We didn't all have all 6 of these at the same time. It started with one and blossomed to other ones. So think of what you're good at. What is your program really good at? What resources do you have? Some things to help you figure it out or to maintain these progress is to build a team. You need to go out there and show everybody what you're doing. You need to target to the junior faculty, people that are interested in teaching, and get them involved. But it takes a group of people to involve. As a faculty director or faculty advisor in these programs, show them the way. You're just a guide, but you're helping them bridge the gap to where they are at to where they want to be. And it takes a lot of people. But you have to have a torchbearer. We usually have 2 faculty advisors. It helps balance the work, keeps them, we can't give them any dedicated time, but it is, they get a lot of mentorship opportunities. They get academic advancement. They get lots of projects that they can put on their CV. Ways to keep those faculty advisors going and retain them is to nominate them for awards, give them a routine acknowledgement and academic. It really helps if you're academically promoting them. But all in all, these programs are driven by our residents. It should be resident run. It should be directed by them. Something that we've done recently is we've sort of designated a track czar, as I like to call them. It's somebody to be a liaison between the faculty directors, the faculty advisors, and the leadership team, just to make sure everything's going okay, that there's a standardized process and routine. And it gives me a routine report on what's going on in the tracks. The first thing you should do when you have these advisors is have a succession plan. Know who's next. If somebody were to step down, who would be the next person to come up? Start that day one. It's really important to plan that out. It's also important to plan the schedule out. It's important to go through and make sure not all the tracks are on academic days at the same time, just to impact the clinical service. Also being organized, tracking the track, seeing what each resident is doing, what papers they're writing, what projects are they working on. I think it's very important. It's also very important to let the residents know that, they have to take some responsibility, hold them accountable to be productive. If they're getting academic time, they should be productive in producing things. You also need to find a lot of good mentors and sponsors, get them out in the national stage. You'll need financial support. And, that comes through buy-in from the chair, from the vice chairs of education. And I mean, that is the main thing, that you need to get buy-in from the people around you. Otherwise, you're going to have a hard time getting projects done and getting things approved. Ways that we've done that over the years is presenting what at ground rounds, things that people are doing in the different tracks. We recently had our residents start giving at noon conference and town hall, just a 5-minute presentation on what projects they're working on. It helps the people that aren't in a track see what the tracks are doing, so it's not like they just get a free day off. Get them out to conferences, get them posters, but make them sort of see that this could be a pathway for them in academics. Another thing you could do is getting people outside of the tracks to come participate, whether it's a lecture or a workshop. It helps them see inside a black box of these tracks. Also, you can reach out outside of your department or even outside of your institution. Now with Zoom, we have opportunities to have kind of visiting professors, but it helps hype up the program. It helps others get involved outside of the smaller community. It's also a huge way to recruit residents. During the recruitment season, you know, their residents or applicants are very interested in coming here because of these different flavors of tracks that we have. It's a great marketing strategy, and I think it's a great way to get programs in residents to come to your program. I think it also helps keep people in academic radiology. Now, not everybody that does one of these tracks or even the clinical education track or any of those things might stay, but it's a nice pipeline. It's a potential pipeline for future academic faculty. Now, for me, the future, 2 tracks I'd like to see is a health policy track and a leadership track, but I think a leadership track should be a part of a lot of different of these tracks, so integrated. But another thing that we're trying to do is an accelerated pathway where stellar residents who want to go into academic radiology, especially some of the hard to fill subspecialties like chest or pediatrics, a way of doing a mini fellowship, extended mini fellowship in their 4th year, and then starting instead of a fellow being a clinical instructor. That way getting them sort of engaged earlier. Now, just in summary, there are many potential avenues for learning or things you can learn during residency, not just radiology. This is a great recruitment tool for programs, and it's an opportunity to capture future radiologists. I just want to thank my predecessors who helped build these, Dr. Ho and Mullins, former program directors. But that is my talk, and thank you very much. I appreciate your time.
Thank you, Ryan. We'll answer questions at the end. Next is Dr. Kara Gaetke Udager. She's a clinical associate professor in the Department of Radiology at the University of Michigan. She attended medical school at the University of Michigan and stayed at UMich for her diagnostic radiology residency, followed by 2 fellowships, one in musculoskeletal imaging and the second in abdominal imaging. She is also a program director for diagnostic radiology residency at University of Michigan and also serves as division director in the musculoskeletal imaging division. So she's very busy. Her scholarly work has focused on topics regarding MSK imaging, as well as topics on residency training, resident recruitment, and faculty development. Her topic today will be on customizing your journey, the leadership scholar programs for residency and beyond. Kara?
Thank you so much. It's a hard act to follow Ryan, so I agree with basically everything he said. And our experiences with a lot of this have been really similar. And so you can kind of picture me as a second act. I'm just going to kind of focus in on one thing, and that was the specific leadership training that can be offered to residents along the way and to faculty as well. And it's something that I really have enjoyed coming through as a trainee and being able to do some of these things. And I know it's really popular with our trainees. So I'll talk a little bit about that, and it kind of just supplements what Ryan just said. So when I was thinking about this topic, I was thinking about why this sometimes comes up that I'm talking about leadership from residents. And it often comes with questions from applicants to the program. And they'll ask me in interviews during interview season, what are you looking for in a resident? Or like, what makes a Michigan resident? They say that sometimes. Or they'll say, what are you most proud of in your graduates? And for me, there's always a lot of things to say. And I list some of them here. There's many things I'm proud of that our residents have and develop and bring to their next position. And some of these are how good they are clinically. They're compassionate people. They're humble. They work hard. they're curious, they ask lots of questions, they're great teammates. But one of the things that I always point out that's special, I think, about our residents is that they're leaders. And they're leaders during residency, but they're also leaders going on to whatever it is. So leadership is a big thing. And I think it's cool because whether residents are staying in academics or they're going into private practice, it seems like when you follow up with them a few years down the road, they're leaders in something. And it doesn't really matter what. It could be research for somebody. It could be leading some facet of their private practice for someone else. It could be something completely different, like they're a community leader or something like that. And I like to think that they're getting some of those skills during residency. And so it's something I am really proud of. And it's the trainees really doing the work. So I think we sometimes think about natural born leaders and people who just seem to have that charisma, someone that everybody likes to follow along behind. But I've increasingly thought that that's not necessarily the whole picture. I think that leadership can be developed and worked on and improved. And I think there's many, many ways to get there. Not every leader is the same and not every pathway is the same, but it does take some work. And that's where we come in as program directors and faculty and people who are invested in these residents, is that we have to get them to work on these things to have really good skills. So I think sometimes the leadership training in residency happens by accident. So this is like the really informal stuff where somebody's just doing something because, and it turns out to be a leadership experience. So I was just wanting to point out some of those things, like someone who says, I'm going to organize the class board review. They're getting a lot more leadership skills out of that than maybe they realized, or maybe they didn't realize they were signing up for a leadership position, but it kind of is. They have to negotiate and communicate broadly and deal with a lot of maybe sticky situations and things like that. So anything that residents are doing to engage can really be leadership training. And some of them become more formal. You could say a chief resident serving in that role is more of a formal experience. But maybe they didn't really realize that coming into the program. They didn't know they were going to be a chief resident, or they didn't realize how much of a process it would be. So it's kind of cool to watch the residents just doing some things that interest them, that they start to get this leadership training just because. I think the other side of that is that even though people may just bump into this like leadership opportunity, we as a program or as a department can also create a good environment. And I remember people talking to me at one point when I was a trainee about how they want to create this place that's like a fast pool, and a fast pool like made for swimmers who are trying to break world records. And so there are certain parameters of that design, trying to make the pool as fast as it can be for the swimmers so that the swimmers can like show their best. And it's that idea of creating a place where there's so many opportunities and that residents can jump in and just go. And I like to think about that when we're trying to create a place to develop leaders. So I'm going to start smaller and talking about what we do. And in the department, we have some of our own opportunities, and Ryan kind of touched on this as well. There's some things for residents in the department, and there's some things that are institutional, and I'll talk about both. In the department, I think the residents, like I said, sometimes learn leadership just by doing things. That's that informal, accidental training. We can also create some programs, which we've done to some extent, and that might be more approachable for some residents than applying to a program either at the institutional level or at a national society or something like that. So residents might get started easily within the department. And the nice part is, because the training and the relationships are all local, people in the department get to know each other well, and there's networking and mentoring that goes on just because you're working on this together. And that can create great ideas, and it can create strong mentoring relationships. And I think that's a really cool benefit of just having some things in the department. So I've listed some things here we have in radiology. I'm not going to go into detail on all of them, but these are some of the things. And it's not, when I was creating this, I was thinking we don't really have like a leadership track that you would tag on to what Ryan's doing. It's more like we have leadership training within some of these other things. But I'll highlight a couple of them. The first one I want to talk about is very informal. And we probably a year ago would have laughed about how I would put this in a talk like this. But a year or two ago, the vice chair here in education and I and the IR program director decided that we wanted to start meeting more often with the chief residents And it started out very informal. We just wanted to have lunch with them sometimes and to check in on them and see how it was going, specifically with their role as a chief. We thought it was a good way to get a dialogue going between the more central department and the residents, and by meeting and talking with that group. And so we were having lunch, and we would just ask them how it was going and what were the challenges they were facing. And we started incorporating topics, whatever it was that what we thought was relevant. Sometimes it was change management, or sometimes it was conflict resolution, or whatever they had questions about or things that they were dealing with. And it's in the past year or two, it's evolved into this really cool thing that we do once a month. And we have meetings, we sit down, we talk to the chiefs, and it's turned into a really nice, informal, but still, I think, rich experience with leadership training. And they can hear our experiences and we hear theirs. And it's something that would be really easy to do for anyone out there on this talk who is trying to think of something to start with. I think just sitting down with a chief sometimes and talking to them about leadership is a nice way to start. So that's something we've done that we've really liked, and we've gotten to know our chief residents really well doing that. So that's one thing. A little more formal thing, which sounds more like a quality track, so to speak, but really is just leadership training, is our department has a quality group, the Quality Collaborative. And it started out as a working group, and it had different members. It has faculty in it, it has some trainees in it, has staff in it. And we all would get together once a month, and we would talk about projects that we were working on. And these were usually clinical or operational projects. But the goal was not just to talk about frustrations, but was to solve the problems and then to publish, publish papers basically about the work we were doing. So we had kind of some high standards set about what we were actually doing with it. And this was just an awesome experience for everybody involved. And we started incorporating trainees who wanted to participate. So it wasn't every resident, but residents who were interested would apply for this. And for 2 years, they would work with this group. They would come to all the monthly meetings, and then there were some formal things they would do outside of the group. They went to an institutional lean management course and did some modules, some quality improvement modules and things to kind of learn the quality improvement curriculum, so to speak. But mostly they were in the group talking about projects, and they each led their own quality improvement project, basically, with a mentor or two from the group. And every month we would get together and check in with them. And the result, they did amazing things with this. They had multiple publications, multiple talks, people won awards, they changed things that had been normal practice here for a long time. And there were some really strong mentoring relationships that formed. So that was a cool leadership experience that was just coming out of this quality improvement group. And it was wildly successful, and the residents who participated loved it. So did the faculty and the staff. And so that was something, again, that you can get a leadership training for trainees just out of a group like that, which is kind of similar to what Ryan was saying about his quality group. I listed here some of the projects that people did that resulted in papers, and you can see some of the publications. And some of the stuff is interesting. Like the last thing listed here was a resident who just said, we would read radiographs for stool burden on the GI service, and they would say, why are we doing all of these? Why are we trying to quantify the amount of stool? And so they did a comparison of asymptomatic and symptomatic patients to see whether this actually helped anything with clinical management. So it was just some ideas that came out of their day-to-day life that turned into really great projects. So that's locally some of the things that we've done for leadership training. On the institutional level, I want to say I feel like we're very lucky here at Michigan, and you guys may have all the same things. And I feel really grateful that we have so many resources within the institution to send our trainees to, or our faculty to. And we also are very lucky to have the support of the department and the time that we can provide the trainees to be off service to go to some of these courses. There is usually, for an institutional course, leadership course, there's an application process. We haven't had a lot of trouble getting people into it, I think because they're looking for people to participate, and usually radiology can figure out the scheduling fairly well. And these tend to be really popular with our trainees for several reasons. I think one is that the structure already exists, so they feel like they're applying to something and spending their time on something that is going to happen and going to be well structured and robust. So they like the fact that it's already existing, not something informal in the department. The mentors in these courses tend to be great. They're really dynamic, usually like pretty well-known people around the institution who are excited about doing this work. And then the really cool part is you get to meet residents from other programs. So like internal medicine or ER radiology or ER or surgery, and you get to hear about their training perspectives, which is really, really valuable. So there's a bunch of these, and I'll just highlight a couple. One of the new ones that people have really liked, there is a health equity. It's called Equity and Quality Scholars Program at U of M, and so a number of our residents have participated in this. So it's about a 10-month program, and at the end you get a certificate. And they have a pretty formalized curriculum about healthcare disparities where they have topics for each session. And then the nice part is too, they all do a quality improvement project. So residents are going to this about once a month, and we provide them the time to do that, and then they work some on the project. And that's been a really popular recent one of these where you get a lot of training in this kind of leadership. And another one that's been around for a long time is this Healthcare Administration Scholars Program. So this is 18 months, and the residents go every other week for an afternoon. They get off service, and they have a pretty big project that they all work on. And I listed the topics here. So this is kind of like somewhat of a leadership-focused program. They get some information about economics and some other things, but this has been really popular. We've had a lot of residents do this. And they have great leadership skills, and they get to learn from other residents. And so it's been a really cool experience for everyone who's done that one. These were some of the past projects from radiology for people who participated in that administrator's course. And so these are all kind of radiology related things. People came up with these ideas and did really cool projects on them as well. And then there's one more group at the institutional level. This is specifically for chiefs. But U of M has a resident kind of like leadership retreat for chief residents. That's 1 day per year, where they're usually around the turn of the academic year. They have this, and they go over a lot of things about leadership. And then there's another group that's longitudinal, and not every chief has to do this, but they usually have at least one person involved from each program, and they do this kind of like a quality working group again with all programs, so that residents get to talk to each other about these kinds of quality or patient safety issues. And that's a really cool thing too, kind of the same idea of networking with other programs. So I was just going to mention too, is the residents get to participate in a lot of these. And the nice part is for the faculty, we also have things to learn too about leadership. And it's nice to have resources on our side as well. So you guys probably have this at your places too, but there are lots of faculty development courses that are usually like a single event. You sign up for a course on a topic, and it's for a few hours or maybe for a day. I listed some of the things. They have a lot targeted for leadership. So our faculty take advantage of these. Again, usually it's really nice to meet some faculty from other departments and hear about their challenges and kind of share ideas. And these are kind of, because they're more limited and they're like single events, it can be a little tricky to align your schedule sometimes, but a lot of faculty do these. U of M has a more, I guess, a little bit more robust Leadership Academy type course, which is 4 total days. And for this, you get nominated from your department, and you do a little bit more rigorous like exploration of your leadership style and how to interact with others and those kinds of things. It's got a 360 evaluation where you get evaluated by people who might be like your managers, people who you might manage, and then your peers. And they all send in anonymous evaluations of you, and that feedback's usually really, really instructive and kind of humbling and nice to hear from people. And so those are pretty popular sessions as well if you're a leader who's looking to kind of increase your skills. There's a really cool program here at U of M that started out being focused. It was a women in academic medicine program. And so in the beginning, all the participants were women. And then over the years, they started realizing that it would be nice to have, if men were interested in doing this and doing the course, men who had been particularly helpful with advancing women leaders, as everybody should be. They were inviting men to the course as well. So now it's kind of more of a mixed group. But this is, again, a longer leadership course. It's about 14 total days. kind of spread out over a year and a half. And for this one, you get a little more formal coaching, and there's a bigger group project that you do on the institutional level. So that's been a very successful and popular course over the years. And then there's some other leadership type things and more focused, like resident, sort of akin to the resident tracks, where faculty can do a course in medical education, which is about 9 months, and you're meeting every week to talk about those sorts of things. And then there's a quality improvement course as well that's kind of similar to that, where you spend about 9 months meeting with a group to learn about quality improvement. And so the cool part is I was a trainee here, and so I did a number of these types of things as a resident. And then it was nice then when I became a faculty, because there was the same kind of material. It was like there was a junior level and kind of like a senior level for a lot of these types of topics. And I think it just really reinforces a lot of these things that are really helpful skills, and you don't learn in necessarily day to day in the reading room. So my conclusions from this were, for the groups who are just starting out, for inside the department, I think teaching leadership is always good, even if it's informal, even if it's just sitting down and kind of like, talking about your experience. I think it's helpful to do that. It encourages that grassroots type of approach to problem solving and working on making change. And you get really good mentors and really good friends out of doing it. Institutionally, I think the challenge for the programs is trying to get the time and the money to support residents to do it sometimes. But the networking often is what people say is the best part of this, is learning from other departments. I think with creating any of these, doing something where the residents are driving the project is really crucial, because they learn so many things just by trying to drive the project. They learn how hard it is to do that and how hard it is to make a change, which is such a useful thing for them to know. And then I think the other thing is, when they're doing these kinds of things, even if it's this informal sitting down with the chiefs, if you're pointing out to them what they're learning and what they're doing, and saying, all of these things you're doing are leadership things, it tends to really resonate with the residents. And so then they get more interested and they tend to be more engaged with what they're doing. And I think that's a really good thing too, is just to point out the excellent work they're doing. They probably don't hear that enough. So that's been our experience, and I'd be glad to talk more about it. And thanks so much for having me.
Thank you. Thank you so much. I mean, these are really terrific talks. Please, anyone that has any questions, please put them in the Q&A. And while I wait, I don't see any questions there yet, but while we're waiting, I'd like to ask each of you, what percentage of residents actually do avail themselves of the opportunity of participating in these tracks? Or is it something that maybe like for Ryan, is it something that every resident sort of is asked to choose? So I'll start with Ryan.
I'm unmuted. I'd probably say about 50% of our residents participate. I can show you where this is my recent, if you can see that right here. Each of these have a different, this is our classes, and each little thing is whether they're IR or the different tracks that they're in. So a lot of them do. Again, some people are in more than one track, which is fine. But yeah, I'd probably say maybe 50%.
Okay. Kara?
I would say, I mean, I was kind of focused on the leadership stuff. I would say between all these things, yeah, maybe about a third of residents are doing one of those types of things. It just varies a little, but yeah, it gets a pretty good amount of engagement from the residents.
That's very nice. For Ryan, I'm just curious, many of them complete their capstone project in their 4th year. Is that?
Yeah, I mean, it's kind of longitude. Sometimes they'll have a paper and they'll just sort of finish in their 3rd year. And sometimes they have multiple things going on. For the clinical education track, they're always coming up with new things. They're coming up with new physics curriculums and new things to teach. And so, again, even though it's a capstone project, there's a lot of little sub projects that they're doing. So they're way more productive than just the one required capstone project.
Okay, we have a question in the chat. How do you go about securing time and funding for residents to pursue a certificate program? I'll start with, I guess I'll start with Kara.
Well, I think we historically have been lucky at having the chair's support for doing this. And so that's where the final approval comes from, is having the chair decide that this is really important for resident education. And our chairs that we've had have definitely supported that. And so we've been lucky. And then the time for it, like I said, I think it just depends on the program. And for us, we're lucky to have enough residents that if one person needs to be off for an afternoon, we can easily cover that. And so that's how we've gotten away with having people off service. And usually with some of these courses, we'll have maybe 3 or 4 people off service at most on any given day. And so we can just absorb it because we have enough residents. But if you have a smaller program, it might be trickier. And I think that's the downside of these things. But we've had great support from our department.
And the funding is departmental funding.
Yeah.
Ryan?
No, I agree 100%. It's purely like demonstrating to the leadership, like the chair, Dr. Carolyn Meltzer was, when we started all of these things, was very supportive of all of these tracks. And it's sort of it's part of the culture. And so you build that culture and you sort of help maintain it and get everybody involved. And then it's easy to find the time. And like Kara said, is, having enough residents. So we're lucky to have a lot of residents. For smaller programs, it's going to be a little bit harder. But it can be scaled back down, I think. But again, we always have somebody to help out with the clinical service.
Yeah. I'm just curious, for each of your tracks, do you have, especially the ones that are internal, departmental, do you have a specific point person that is designated as, for example, the point person that oversees the quality, the residents that are doing this quality project? Or is it more, each one gets a mentor and then they sort of pick and choose on their own? Kara, start with you.
So for ours, it is, so the internal programs in the department, it hasn't really been formal. We have somebody who's in the quality collaborative, somebody is the leader of the quality collaborative. Within the group, there's a number of faculty, and when a resident's coming in to do a project, sort of like someone who has a shared interest in it kind of becomes the mentor. There is a point person for the group, and we kind of do it that way. And that's kind of, I think, how we do most of our mentoring, is it's usually aligned by the interest and like the skill of what someone's doing in the project. Yeah.
How about you, Ryan?
Yeah, each one of our tracks has, I try to have 2 faculty advisors for each track, and they help monitor and just follow up and make sure that, even though I said it was resident run and directed, they're sort of making sure that they're not burning down the place. And then that track czar helps is sort of a resource for those faculty advisors, and a way for me, because it's hard for me to manage 60 plus residents and then the tracks and things like that. So it's nice to have somebody to sort of summarize what's going on and help out. So it's a very organized thing, but they have mentors outside of those track advisors as well.
Okay, yeah, that makes sense. And it's of their choosing, or the faculty?
Yeah, we don't have a formal sort of mentorship program here. I've talked to a lot of different programs. Who am I as the program director to say, this is your mentor and this is your mentee? Now, if I feel like somebody's struggling, then I can do that. But here it's very organic. A lot of our faculty want to be mentors and want to be involved in projects. And again, it goes back to that culture. That's sort of what we want to have happen. And that's what it's not expected, but it's just what happens for the most part.
Yeah. Okay, great. I just want to ask any of the participants if you have any more questions, you can put them in the chat. Yeah, I guess while we wait just for a couple more minutes, I wanted to say, here at NYU, we do have our research. It's not an official research track like yours. We do have opportunities for our residents to take time for academic time, to do dedicated time to do research with a mentor, and they have to like submit a project and whatnot. But I'm going to say that it can get unruly in terms of when you have everybody taking the time, and you need somebody to really oversee what's happening, because as a program director, it's very hard to follow.
And a lot of that is program coordinators and your chief, like we utilize our chief residents a lot to, and blocking that research time. We used to have it where it would be like once a week, the residents would reach out to their faculty and be like, hey, I'm taking my research day on Thursday. And it just sort of disrupt the clinical service. And so it's nice. One of the biggest things I've seen help that is blocking that time and scheduling it, and having the hospital, not hospital, but not just my program coordinator, we also have a manager for research, help make sure that we're giving them that 20%, or if they have a grant or something like that, making sure we're being held accountable for giving them the time that they're being paid for, like getting those grants and things like that. Now, it'd be nice to have a T32 like UCSF and some other places to have that grant money, but it's a very difficult. You need a super czar, somebody that has the time to manage that. That's a very big ask. We don't have that, but I think we do a pretty good job of giving protecting that time for our residents.
Okay, great. Okay. Don't see any more questions. And so I would like to give you guys back a couple of extra minutes. So I just want to really thank our speakers, both Ryan and Cara, for doing such an amazing job on their presentations, and the attendees for attending and some of your questions. And have a nice evening, everybody.
Thank you very much, Dr. Mercado. Thank you, everyone.
Thank you.
Thank you.